we have lined up excellent speakers to cover various aspects of this session. I'll be taking up perfect biometry, can we do better? Then Dr. Santosh Bhide sir is going to talk on perfect surgery, consistent and reproducible results. Dr. Neeraj Manchanda is going to cover if we have PCR, can we achieve 20 by 20 in a case with PCR? Dr. Anand Parthasarathi is going to talk on phaco in post-keratorefractive surgery eyes. Dr. Jaspreet Sukhija from PGI is going to talk about optimizing results in pediatric cataract surgery. Dr. Nivian will cover up the topic of choosing the right IOL, monofocal, multifocal, trifocal or EDOF lenses. Dr. Parul Sharma will cover the part of astigmatism and optimizing toric IOL accuracy. Dr. Sachin Mahuli will cover cataract surgery in post-retinal surgery eyes, and Dr. Vanashri will talk on tackling refractive surprises post-cataract surgeries. So we start with the first talk of the day. This is how important is perfect biometry. We all know that in earlier times, cataracts was removed first and spectacle prescription was given last. But today we calculate the power of IOL first and cataract surgery is done afterwards. So IOL calculation plays a very important role to determine refractive outcome after the surgery. Since 75, just two parameters have been used, that is keratometry and axial length. But today we can customize the power of IOL to achieve near plano results even in highly myopic, hyperopic, or in extreme eyes like post-keratorefractive surgery eyes. Group of patients who greatly value their emmetropia, and when you tell them that they are required spectacles after the cataract surgery, they are extremely disappointed. And what are the major sources of prediction error for IOL power calculation? ELP prediction accounts for 35%, followed by axial length for 17%, keratometry 10%, and post-op refraction for 27%. And few subjects in the field of ophthalmology are as complex as IOL power formulas because it involves the use of mathematics, and we ophthalmologists are not very fond of mathematics in our field. And there are some hurdles in accurate estimation of effective lens position because older formulae, they worked on some assumptions. That is, the shorter eyes and flatter K eyes were supposed to have shorter anterior segment and shallow AC, accounting for shorter effective lens position, in contrast to longer eyes and steeper K eyes, which are supposed to have deeper anterior chamber and thus longer effective lens position. But Holliday taught us that there are 9 types of eyes. Eyes with normal anterior segment, 80% have short axial length and 90% have long axial length. And eyes with normal axial length, 2% may have short anterior chamber depth and 2% may have longer anterior chamber depth. So relationship between the anterior segment size and axial length is not proportionate in 80% of the short and 90% of the longer eyes. So older formulae are bound to fall in short and long eyes. Earlier formulas also had some more assumption. That is, they assumed a fixed ratio of anterior and posterior corneal curvature. Cornea was treated as a thin lens with 1.3375 refractive index. Actually, it is 1.37. Cornea was treated as sphere. It is a prolate. So it used to give us correct result in average eyes, but not in atypical and extreme eyes. So is it bad to just keep using the older formulas? Yes, because then with older formulas, only 1% of the surgeons achieved accuracy within 0.5 diopter in 92% of their cases. So this was a Rayner medal lecture given in 2016, and that they said it is possible by using newer formulas, we can achieve 91% of eyes within 0.5 diopter of the target refraction can be achieved. And so what are these newer formulas? I'll straight away jump to the newer ones: T2, Hoffer H5, Ladas, Olsen, Barrett True K, Barrett Universal, Hill RBF, Kane, EVO, and VRF. Prediction theory says if you more the number of variables to describe an event, more accurately outcome can be predicted. So as we move from 2 variables of axial length and keratometry to higher numbers, the accuracy improved. So we have 4 variables in Olsen, 5 variables in Barrett, and Holliday has 7 variables. Artificial intelligence is used in Hill RBF, and ray tracing is used in Oculix and phaco optics. And we also have some constants to give us idea about the effective lens position. SRKT had A constant, Hagees had A0, A1, A2, Hoffer Q and Holliday 2 have anterior chamber depth, Holliday 1 has surgeon factor, Olsen C constant, and Barrett has lens factor. But if these lens constants were arrived in earlier days when plano-convex lenses and contact ultrasound biometry was used. So we have to optimize our A constants, and you can optimize your A constant either with your own cases, or you also have various softwares like Dr. Holliday's IOL constant and Dr. Hagee's ULIV website. Surgeon who does not personalize his A constants, you'll find that on the left side, the accuracy within 0.5 diopter with the older constants was just 18%, and it jumps to about 70%, and within 1 diopter it jumps from 50% to 95%. Barrett Universal 2 is a newer formula which is recommended for all types of eyes, short to long eyes. Hill RBF uses artificial intelligence and pattern recognition, and it gives us better accuracy up to 91%. Olsen formula uses ray tracing. LADA Super formula is an intelligent formula because it combines the best performing portions of multiple third generation and fourth generation IOL formula. Kane formula uses, besides axial length and keratometry, also anterior chamber depth, lens thickness, CCT, corneal thickness, and gender of the patient to make its prediction. EVO 2.0 formula also uses these parameters, and it is also giving us good results in shorter eyes. Intraoperative aberrometry is not going to make lens calculations obsolete in the near futures, and its indication is in post-refractive surgery and astigmatic in toric IOL calculation. Ray tracing is used in Oculix and Olsen's, but there are limitations of ray tracing formulas, and it is not outperforming the standard formulas because they still depend on the accurate estimation of the effective lens position. So there is no reason to switch to ray tracing formulas. Hill RBF not only gives you IOL power, it also gives you accuracy level, whether it is inbound or out of the bound indication. So if we compare Barrett and Hill RBF, both are current, both are more sophisticated, although they use totally different premises, but they give us recommendations which are within 0.25 diopter of each other. So what should I use? Should I use multiple formulas and compare and average the results? Douglas Koch follows this policy. But Holliday, Barrett says use specific formulas for specific situation. So what is the best way to deal with shorter eyes? The best way is not Hoffer Q, which was traditional wisdom. It is better to use Barrett or Hill RBF. So, and in shorter eyes, these are the various studies which have been published, and they found that after Hill RBF and Barrett, even Kane formula is also giving us, Kane EVO are giving us good results. What is problem in longer eyes? That we get hyperopic surprise because the biometry tends to measure axial length longer than it actually is. So in longer eyes also, the older generation, third and fourth generation formulas are not giving good results, and we are slowly switching over to Barrett, Hill, RBF, EVO, and Kane formulas. And mind you, all these formulas are free of cost, available on the website. You can go there, feed your data, and get the results. So this is a meta-analysis which has been published, and you will find that within the first most accurate formulas, Kane, EVO, VRFG, Barrett Universal 2, Hill RBF, Pearl DGS are there, and you will find that Hoffer, Hagee's, Holliday are not there in the most accurate first 5 formulas. This is another study which was published by Melis, and they also gave us similar results. So what are the steps you can do to maximize the likelihood of getting better outcomes? Please optimize your lens constants, validate your measurements, particularly if you are getting readings which are outside the normal range of axial length, corneal power, and the difference between the eyes. Please take measurements yourself in post-keratorefractive surgery eyes in shorter and longer axial lengths. Do not delegate this responsibility to your optoms because you are the most knowledgeable person of the team. Spend extra time counseling patients with short eyes or previous refractive surgeries, and please update yourself and switch to newer formulas. So we have reached accuracy of 90% within 0.5 diopter. The problem is not the formula any longer. Problem is the precision limit of the various variables which are used in the formula. And the precision limit for keratometry is 0.25 diopter. For axial length and anterior chamber depth, it is 0.1 millimeter. So these errors keep us at about 90% accuracy level. And there are also some ISO permitted tolerance. Imagine your calculation is 21.3 diopter. Nearest power available is 21.5. And ISO permitted tolerance for 21.5 is 0.4. So you wanted to implant 21.3, but the actual power implanted is 21.9. So you have given error of 0.6 even after you have done excellent calculation and excellent surgery. So has the stage come where we can use single formula for all eyes? No, we are still not reached that stage, but the formula which comes closest to it is Barrett Universal 2. So because this gives us accuracy in all short, long, and the medium size eyes. So improvements in technology have allowed accuracy of biometry to double every 5 to 10 years, and 90% accuracy is now achievable. So we should strive for what is achievable and not what is acceptable. Smartness is learning not only from your own but also from others' mistakes. So let us not only become experienced but also smart. And we are now on the verge of level of accuracy never before seen in ophthalmology. But for this, we have to use validated measurements, optimize your lens constants, and adapt to near technologies. Thank you, everyone, for your kind and patient hearing. Now I'll invite Dr. Santosh Bhide sir for his talk.
And at the outset, I would like to thank Bhalla sir for giving me the opportunity, and of course the AIOS Scientific Committee for giving such a nice time for this talk. Dr. Bhalla sir has already talked about biometry, perfecting. See, we are lucky, our generation is such that we have access to a lot of gadgets and we can try and perfect our surgery. There are no financial interests. We all know that there is a lot of cataract burden for all of us to treat, and there are very high expectations amongst patients because they are aware of various technologies, and as a surgeon it's our aim to give the perfect results. So basically there are two aspects. One has to be perfect in the technique, what we perform, and second is we have to do all this technique consistently and give reproducible results even in challenging situations. And I am sure the speakers after me are going to talk about challenging situations like PCR and other aspects of it. Before we think of perfecting the technique or giving the perfect results, the most important step which we must follow, everybody, is that preoperative evaluation. Whenever we have a huge list, especially we tend to skip doing examination of the patient ourselves. So it's always better to check the patients before operating on slit lamp, thorough slit lamp examination, AC depth, watch for corneal opacities, dense arcus. Most important is if you are planning for premium IOLs, evaluation of ocular surface and ruling out dry eye is a must. And you have to rule out zonular instability. There are many times surprises on the table. We miss zonular instability in preoperative examination, and on table we are fixed because then we find that there is a lot of zonular instability. If you are planning toric IOLs or toric multifocals, topography is a must. And I feel ideally for all the cases we have to do detailed retinal examination prior, and OCT should be done in all the cases if it is possible. Biometry, Dr. Bhalla sir has already talked about, and there are certain intraoperative tips which we must understand. You have to avoid blunt keratome, that is a standard, proper staining, avoid tight wound, and Arshinov technique is the best thing. In modern cataract surgery, I think the most important step in phacoemulsification is capsulorhexis, and integrity of the capsulorhexis edge gives the strength to the capsule to withstand all the fluctuations in intraocular pressures during fragmentation of the nuclear fragments. So to understand capsulorhexis, there are basically different forces which act on the capsule during capsulorhexis. These are 4 different forces. The extrinsic force which is applied by the surgeon during capsulorhexis. There is always a centrifugal pulling force by the zonules. There is always leakage of OVD from the wound, from the anti-aqueous, which again leads to extension of capsulorhexis at the periphery. And another important aspect is the posterior thrust from the vitreous. So if we know all these forces, then it's quite easy to perform capsulorhexis consistently. Capsulorhexis has to be of adequate size. Whatever technique you are using, it should be of adequate size. If you are performing a manual small incision cataract surgery, I won't call it as a not good surgery. It's good in certain particular patients where there is a dense grade 5, grade 6 black cataract. You can always do manual small incision cataract surgery. In that, since the nucleus is of bigger size, you should aim for a bigger capsulorhexis in such case. While performing capsulorhexis, always maintain the depth properly. If there is leakage and if you find that anterior chamber is collapsing, then it is always better to refill the anterior chamber with viscoelastic devices, so that you have to maintain the anterior surface of the cornea, anterior surface of the capsule flat. In intumescent cataract, it's better to aspirate the intralenticular fluid prior to the capsulorhexis, and there are various forces, basically shearing and tearing technique, which you have to apply properly to complete the capsulorhexis. So ideal capsulorhexis, we all are aware, should be of 5.5 to 6 millimeters, and it should be properly centered on the visual axis. The next important step in phacoemulsification, because phacoemulsification is a gold standard in modern cataract surgery, is management of nucleus. And in management of nucleus, you have to protect endothelium properly. If you want good results on the day 1 postoperatively, endothelium has to be protected. For that, you have to select proper viscoelastic device depending on the grade of the cataract, and Arshinov's soft shell technique, all we know, is the best way to protect the corneal endothelium. There are various techniques you can do: 4-quadrant, stop and chop, direct chop, whatever works best in your hands. In most of the cases, or in all the cases, you can follow. I feel stop and chop is the best technique to treat all grades of cataract, and basically it is stress free for the surgeon. If you try other techniques like direct chop and all, there is some amount of stress amongst the operating surgeons. As far as the machines are used, I still feel no financial interest. The torsional phaco Ozil technology is the best to cut all grades of cataract properly. So this is a short video which shows that it's a quite dense cataract, and we are trying to remove it by a stop and chop technique. A proper trench has to be created. Once you create the trench, you can just crack the nucleus. Time up, or I have some time?
Have a minute more.
Okay, fine. And then even such a dense cataract can be easily removed with stop and chop technique and proper use. So to summarize, if you want to give all the perfect result in all the cases, it's always better to do proper preoperative assessment. You have to plan the surgery depending on the grade of the cataract, type of the cataract. Avoid repeated entry into the anterior chamber, avoid tight wounds to avoid wound burns, avoid excessive phaco power, proper selection of viscoelastic in the back phaco. And there is a concept of 1 minute phaco. At the end of 1 minute, you can just refill anterior chamber with viscoelastic device so as to protect the endothelium, and see to it that the viscoelastic device is retained in the anterior chamber throughout the surgery. Another important thing is, as a surgeon, you should not have ego that you will do all cases phaco in 1 minute. Speed is not I have finished case in 2 minutes or something like that. The recovery time for the patient has to be fast and not the surgical time. So kill your ego, safety first, and then I am sure that you will achieve good results in all the cases. Thank you, Dr. Bhalla sir, again for giving the opportunity. Thank you.
To the results. So now we have the next talk by Dr. Parul Sharma. She is going to cover optimizing toric IOL accuracy.
Good morning. Thank you, Dr. Bhalla. A very warm welcome to all of you. So he's given a very good overview on the biometry, and it's all about refractive cataract surgery these days. Hence, the importance of getting your toric IOLs correct. So I'll divide my talk into these 3 sections as to how we can improve our toric IOL precision. Preoperative, very, very important. I'll show you some slides on how dry eye and OSD evaluation matters. We don't think much about it when we are doing biometry, but this is a very key area to be looked into before we even start and think about our biometries. Most of us have optical biometry, but even if you do not, doesn't mean that you cannot target 20 by 20. Take out the immersion of your A scan. Make sure that your optoms are at least doing the immersion A scan very well. Don't rely on just one keratometer. I'm sure all of us have auto K in our auto ref. You have your manual kerato, even a basic topo readings. So these three readings, I would say, would help you in assimilating things. SIA, I'm going to talk about when we talk about the formulas. Now, how to avoid errors. Always do biometry before applanation and dilatation. Young cataracts are happening more these days, so take a history of contact lens wear because this is also going to affect your reading. When it comes to keratometry, we know that the axis and the diopter is so important for toric IOLs. If you feel that the patient has dry eye, use lubricating eye drops before you do your K. Optical biometries, as I said, take readings from at least 3 different instruments. Always compare both eyes because you may pick up something where the readings have been off and if it's not compatible. Topo is a good place to look at your symmetry of the astigmatism and the axis. If there is a confusion in the axis between the manifest refraction and what you're getting on cornea, look at the topo. Very important if you have optical biometries to tell your optom and remind him to calibrate it weekly because if your machine is off, your results are going to be off. Now, how many of us have actually looked at a patient when the biometry is being done? If there is a head tilt, it affects your axis results. There are enough literature and publications which tells us on how it affects. So this is for demo purpose. I've taken the patient. You can see in the first slide, there is a head tilt when we are taking the optical biometry. When I put our head straight and repeat the biometry, the axis changes by almost 10 degrees. So this is a very, very important step. Again, as Dr. Bhalla said, look at the outliers. So when your optoms are doing the biometry, they are not so aware that the machine highlights these yellow points and your standard deviation is higher. The moment you remove the outliers, your standard deviation becomes much less. So accuracy again is required here. So as I said, OSD and dry eye. So these are multiple areas where your ocular surface will affect the outcomes of your biometry and precision of the IOL power calculation. So first, optimize the ocular surface, whichever way the patient, depending on the dry eye, you may need tear supplements, anti-inflammatory drops, steroids, immunomodulator. If it's a meibomian gland disease, then you can first do the treatment, get the tear film okay, and then proceed with your biometry. So the idea here is to sensitize you that look into dry eye situation before we talk about the precision because that affects your outcome. So here again, a patient, this is before the treatment and after treatment for 2 months, you see even the model of the toric IOL has changed. Now, which IOL formula? This has been very well covered by Dr. Bhalla earlier. Barrett has made our life very, very easy. We don't have to bother much about it. If you don't have an optical biometry, as I said, use your immersion scan, take readings from different kerato, and there are immensely, great online IOL calculators. So put these reading, trains your optoms to put these reading onto the online calculators, and you can pretty much deal with all kind of eyes with as much accuracy. Now, how do you refine your biometry for toric IOLs? As I said, SIA. Now, SIA is incorporated in the formula. We always, when we are starting young, we always get very hassled by what is this SIA. It's very simple. Just take data, tell your optoms to keep a data of say around 50 patients. Take your pre-op, post-op refraction, your kerato values. This is all what they need. If you don't want to do it online, you can give it to the company guys. They will calculate your SIA and that you incorporate into the formula. So that's the first thing which you should do when you go back home, make an Excel sheet, tell your staff to start putting your data there. It also helps you to analyze how your results are. Now, small torics, if it's a with the rule 0.2, 0.3, and you're not sure that do you really want to do T2 because you say, asking the patient to spend at least 10,000-15,000 more, you can optimize it by manipulating your incision. So if you see here, I've changed the incision size and the T2 model has become non-toric if I am not being temporal in this case and I'm using a superior incision. So for very small astigmatism, you can do that as well. So this was a similar case where after changing the axis, in the first case, on the temporal axis, it's coming as small model of T2, and when I change the incision size, it's becoming a non-toric. So you're also making it cost-effective for the patient with the same result. Always compare the biometry of both eyes. You may pick up some error, and if there is a gap, it may not just be an isometria, it may be a measurement gap. So remove the outliers and re-look at the situation again. High hyperope, Dr. Bhalla has already mentioned that there could be error. So in this particular file, when you pick up the formulas, just don't rely on the Barrett 2. Also look at Holiday, also look at other formulas and see what an average is coming out to be like. Now, we've spoken about kerato, we've spoken about tomo. Is tomography important? Do we need to have pentacam and series? Not completely necessary, but it always helps you in giving that extra reading. Why? Because the whole paradigm astigmatism has now shifted to posterior corneal astigmatism. So all these machines give you posterior corneal astigmatism, and we know that this adds or subtracts from your anterior surface astigmatism. For example, in the first patient here, you see the amount of cylinder is same in both the eyes. 0.86, 0.93, it's a with the rule. So see the model that we have picked up, the machine has picked up is a non-toric in the first one. Vis-a-vis the second case, where it's against the rule, but it adds on, and here the model is T3. So it's important to know that the posterior corneal astigmatism, so you don't want to miss out posterior keratoconus, hence, and so forth. So also, in your pentacam and other machines, at least you will know whether it is a regular astigmatism or an irregular, and you plan your toric. You're more confident it's an asymmetrical. Highly asymmetrical, you may skip. Just one line I'll take on this slide, because I think we have one speaker less. Should I finish it, Dr. Bhalla?
Yeah.
So, Barrett True K for post-refractive surfaces, ectatic corneas. Again, you don't need optical biometries, you can plan it online. Keratoconus is one area where we all struggle with the toric lenses. If it's a mild to moderate KC, and if you've seen your anterior sagittal curves and your astigmatism is regular, you can confidently go ahead and do toric. But if it's a very asymmetric, very highly irregular cornea, post-PK, highly ectasic, pellucid marginal degeneration, your toric patients won't be happy, so you have to counsel them, go with a spherical lens and compensate for the astigmatism in spectacles. That's a better idea. So pre-op marking, we all know, I don't think I have to go in it in much detail. We have slit lamps, we have smartphones, we have gas bubble markers. I have a image system also, had taken it for a demo, so recorded some cases. So this actually does help in planning your surgery better. 2 points in the toric marking, because we are talking about how to refine. When you're doing the corneal marking, always ask your attendant to dry the cornea before you do the marking. Ask them not to do the central part, like you see how I got this mark because the assistant had marked on the center also, and then it keeps bothering you during the surgery. And adequate rexis size, because you don't want toric IOL rotation. So image guiding system, or whichever way you want, 5.5, there should be a little overplay of the capsule on the lens. Now, a small tip when you're putting the lens in, because you don't want the lens to rotate, when you're putting the lens, just make sure that the axis is actually 10 or 20 degrees short of the actual corneal marking. So here you see that the axis is probably around 180, and I've left it at 160, 170. And when you're doing your IA, once you finish that, simply with just the IA cannula or the hydro cannula, you can match the toric IOL and the corneal marking. In very large eyes, myopic eyes, you can put a CTR to avoid the rotation of the IOL. So post-op refractive surprise, just know it could be because of any of these factors. Just know that astigmatismfix.com really makes it very easy for you. Till the time we haven't used it, it seems like a very big deal, but you can just manipulate and create a situation in your OPD and just play with it for 1 or 2 times. Pretend that your patient has a surprise and put in the readings, and the machine will very easily tell you on how to rotate and where to put the axis. So just to summarize, the pre-op work is very important. I think we've highlighted how OSD dry eye can be used. Immersion is as good, even if you don't have optical biometers. Make sure that your machines are calibrated well. Health tilt is very important. Removing outliers, a consistent post-op evaluation of your cases helps in refining your toric IOLs, and talk to the patient more, explaining him what the expectations are and what you're going to do. Thank you so much.
Thank you, Dr. Parul. We'll have questions at the end of the session. Now I'll invite Dr. Neeraj Manchanda. He's going to talk on achieving 20 by 20 with a PCR.
Good morning, everyone. I must thank Dr. Bhalla for inviting me here, and the AIOC team here, who has done a wonderful conference this time. Beautiful food arrangement also, plus the local organizing committee. I must congratulate them for doing such a wonderful job. So my topic is achieving a 20/20 with a posterior capsular end, PCR in short form. So I hope anybody who's operating this dreaded complication once in a while can happen or may happen, especially when you are in a teaching institution, you see these things day in and day out. So what are the risk factors of a PCT? If initially you see there is a poor visualization, cataract which is posterior polar or a posterior traumatic cataract with a tilt, subluxation or a small pupil and weakened zonules, or if it is a vitrectomized eye, that is the point to become cautious. And if you are not a very good surgeon, try not to do such cases under topical anesthesia. I am mainly a topical anesthesia surgeon, but if such cases come and we are sure that something may happen, then try to give a local block. So what are the predisposing surgical factors? Surgical factors could be a small capsular excess, not the exact size you intended. It could be an extended capsular excess, it can happen once in a while, uncontrolled hydrodissection, surge in the faulty machine, running after small pieces, or improper IOL insertion. I have given highlights of what can happen during surgery, even if pre-op there was no problem. So what are the signs of impending catastrophe? When you are operating, if there is a sudden deepening of anterior chamber, go slow, stop, think what is happening, what you might do, what can be done to correct the things, dipping of one pole of the nucleus or altered reflex in the periphery. So what an anterior segment surgeon can do? Zonal dialysis, like I told, can take place at any stage or with any surgeon at any time in his life. I have been operating for last 25 years now. Still I am not free of any PCTs or PCRs, although they are very, very rare, but it can happen because the more senior you grow, the more complicated cases start coming to you. So it can happen with any surgeon. The thing is not to panic. I myself am doing retina also. I do retina as well as cataract, so panic in my cases are less because if there is a problem, I myself can do the complications and operate them. So a PCT always does not mean that there is a vitreous loss. I'll show you a video how to avoid vitreous loss. So maintain the anterior chamber, don't panic, don't take out the phaco probe in a hurry. Use viscoelastics liberally. If there are any problems, use viscoelastic. Viscoat is the good viscoelastic. Do a dry aspiration in case if there is a problem, and in case of zonular dialysis, use an endocapsular ring. So this is a small video. You can see here, this is a posterior polar cataract. Already this is being done in a local anesthesia, no topical for such cases. So you can see a hydrodissection being done, and now you can see I am taking out the nucleus, and you will see somewhere in between there, that is the rent you can see there. So you can see this popping out. The vitreous has not come out of the anterior chamber, and doing a slow aspiration with the help of viscoaspiration. This is called viscoaspiration under viscoelastic, and now extending the posterior axis because wanted to remove that bad part of the posterior capsule. So after that, a shallow vitrectomy, removing the Visilon. The vitreous has still not come out, and then you can put a IOL and do an optic capture, and the end result is very good vision. Vitreous did not come out, although we have just shaved the vitreous at the bottom. So you can see a good result, patient happy next day. So what happens if there is vitreous in the anterior chamber? Please do not use the phaco probe to remove the vitreous. It will keep on pulling and tugging, and you can cause rents and tears in the retina. Clean the vitreous around the nucleus and do a dry vitrectomy like I told, and visco-assisted vitrectomy, that is the rule. No fluid. Basics of management, what is the common mistake we do? We suddenly, when we see something is happening, we withdraw the phaco probe. If we withdraw suddenly, don't maintain the chamber, the vitreous will tend to come out. We want to leave the vitreous in. Never let the chamber collapse. Conventional methods like cutting with a scissor like we used to do with a Merosil sponge. Earlier there were no good vitrectomy machines, but nowadays all phaco machines also have a good vitrectomy. The main problem is, although the machines have the vitrectomy cutter, this I tell in every session, the cutter is not available at the time you want to do the vitrectomy. Always keep 1 or 2 brand new cutters in your store, that is important. So cutter, new cutter always should be there because machine has a cutting facility, but we don't have the cutter, then what to do? So automated vitrectomy is the right choice. So where is the problem? Problem is in our head. You don't have to worry. Anybody can do it. It is a very simple procedure. And basic principles are cut before aspirating. Don't aspirate, cut before aspirating. No pulling, no hydration. Balance the fluid egress. The chamber should be maintained. Direction of the cutter should be anterior, not posterior. And section and anterior chamber should be the vitreous-free zone at the end. And automated vitrectomy, again I'm telling, preferably a new cutter. The rules of anterior vitrectomy are bimanual irrigation and cutting, remove vitrectomy completely from the AC, free the corneal and scleral wound, and free the pupil. These are the basic points. You can see an older video which I have got. This is again a relatively small pupil, moderate cataract. So rex's size is little small. Ideally we should have used pupil expander, but this is around a 15-year-old surgery, old video which I had. relatively grade 2 to 3 cataract, doing the hydrodissection. So you can see what happens during surgery also, you can create problems. So this is the nucleus being aspirated, phacoemulsified, and now you can see what is going to happen. This is the epinucleus. This is the time when you have to be most careful. I tell all my residents to be careful at this point. See, this is what has happened. Again, a small rent you can see, the phaco machine, sudden surge, and there it goes. So you have to be careful when these things happen. This is how we do a dry vitrectomy. Again, using viscoelastic, aspirating using lot of viscoelastic, aspiration with a cannula, and doing the, anytime the vitreous comes, try to cut it in between, remain in the center. So these are the basic principles. So after this, you can put a IOL also. So what are the more ticklish problems? Nuclear pieces in vitreous. Sometimes what happens, this was just a small rent. What happens is the nucleus, there are pieces of the nucleus, they keep on rotating all around. They are going back, they are coming around. Whatever may happen, don't run after the pieces. You will be more tired and thirsty. The more you run after them, the more problem they will create. So if you are not a qualified vitreous surgeon, please don't go ahead. You can leave it at this stage. There is no need to panic. If there is no vitreoretinal surgeon available, just close the case and leave it for the vitreoretinal surgeon to complete it. The end results after a few days will be the same. You don't have to worry, but the thing is to tell the patient what has happened. That is important. What you should not do is try to remove the nucleus pieces and put wire vectors in the vitreous. Sometimes we have tendency to go in and come out and take the whole pieces out. That should not be done. So management, same sitting. If you have a VR surgeon or you are qualified vitreoretinal surgeon, or deferred, refer to your surgeon friend, vitreoretinal surgeon friend. He will give a good result. And don't worry, vision, most of the time, most of the cases I have also operated, people get good vision. Your present imperfect handling of vitreous may make your future tense. And what you can do is anterior vitrectomy, cortical cleaning, IOL, if you are okay with it, you put it, otherwise your vitreoretinal colleague can put the IOL for you. And last but not the least, another very old video, what not to do is shown here. This is around 20-year-old video.
Neeraj, can you summarize, please?
This is last slide, sir, one slide. This is 10 more seconds. So this is what you are doing. See, I am taking out the already rent is there. You can see we are taking out the vitreous, doing a aspiration and vitrectomy. You can see the big nucleus there. There is a big, huge nucleus there. What is going to happen is, see, it is going down. It has gone down. My message is, if it has gone down, let it go down. Leave it for the VR surgeon. Don't try to pick it up. And then you can, at the end, put the lens if you want. And this is my message for surgeons for achieving a 2020 again. Do not fish for the nucleus. Thorough anterior vitrectomy. Remove cortex with dry aspiration. IOL insertion only if you are confident, and refer to a vitreoretinal surgeon. Thank you very much.
Thank you, Neeraj. Now I'll invite Dr. Jaspreet Sukhija. He is going to talk on optimizing results in pediatric cataract surgery.
Can we have this? Very good morning to all of you, and thank you, Dr. Bhalla, for having me a part of this session. We've heard some great talks by prolific surgeons, achieving 2020 within a couple of days. But in children, this is not really possible. You do target a 2020, but maybe it takes years. It all depends when the child presents, what is the laterality of the cataract, and how the surgery has been done. So a lot of issues come into play. It's not just you have the best of formulas and you can get an accurate results. You aim for some target refraction, but then you have surprises in children. So I'll be discussing some of these issues in this presentation. My meaning of pediatric cataract surgery is like infants and toddlers. Children who are above 5 to 6 years usually have a more or less stable axial length and behaves like adults. So I would be stressing more upon the infants and toddlers. So in children, if you have a bilateral cataract, your management is different. If you have a unilateral cataract, it's all the more difficult to achieve that 20 by 20 vision, because they would have strabismus and they would have deprivational amblyopia. So in children, you have to deal with what's the cause. Is it familial? Do you have some kind of a syndrome which is affecting it? Or is it kind of just an idiopathic cataract? So all these things in examination is a must. A consultation with the pediatrician is must to get the optimal outcome. So what are the areas of concern in a child with cataract? You have a small palpebral aperture as compared to an adult. So if you have a 3 or 4 month old child, it's very difficult to get into that small space. The eye is soft. The anterior chamber is shallow. Obviously, difficult manipulating those big instruments into the anterior chamber. The pupillary dilatation is the biggest problem here, because the The receptors for epinephrine are poorly developed and the uptake is very low. The dilator muscle is not that well developed, so your pupil does constrict and you have to have a good pupil size for a better surgery. What is the optimal age? Whether would you like to operate in a neonate or would you like to wait for a month? There are risk of GA, inflammation, glaucoma, amblyopia, everything is there. Would you like to implant an IOL or leave the child a phakic? What is your target refraction? Emetropia, myopia, hyperopia? Where do you want to put the IOL? Because you're going to have visual exopacification if you don't do it properly. So all these things are very important. And of course, whether you want to do both eyes or whether you want to do single eye, because again, the GA risk is there. And of course, whether you want to implant a unifocal or an enhanced monofocal or a multifocal. So there are a lot of things in a child if you have to achieve a good visual outcome. So I'll just take you a brief overview of all these things. So the best visual outcome is during the first 6 weeks in unilateral cataract, and for bilateral it is 8 to 10 weeks. It's more related to patching and compliance. As I said, amblyopia is a big issue in these cases. If you do very early surgery, it's been related to that there's a high incidence of glaucoma and inflammation, and of course more risk with general anesthesia as well if it's very early. So the consensus is all non-essential surgery to be done after 4 weeks. IOL or aphakia in infants. Well, there are proponents and opponents of this issue. If they are children less than 6 months, probably just leave the child aphakic. But above 6 months, the consensus is more in favor of an IOL. So this is one of our studies which we did, a prospective study in infants versus a very popular study, the infant aphakia treatment study, and we found that our results of resurgery were much less as compared to the Western literature. IOL power calculation, as has been highlighted in adults, there's so many formulas, but what happens in children? In children, really, they're not fixing. You have to do your axial lengths when under general anesthesia, so you're bound to have surprises. But if you want to implant an IOL, one basic rule is have an axial length of more than 17 millimeters. Your corneal diameter should be 10 millimeters or more. And now as the acceptable age is becoming progressively younger, what is the optimal approach for determining IOL power in these children? So the refractive goal is myopic shift is going to occur because your axial length is increasing, you're going to have myopia. At what age would you like to, and what target refraction you want to achieve, like for a 1-year-old versus a 3-year-old is all different. These are debatable issues. Usually what we do is, depending upon the axial length and the keratometry, one chooses what IOL power can be implanted. So at birth, you can see how steep the cornea is, and most of the axial length elongation would occur in the first 2 years. So the average myopic shift is about 6 to 7 diopters, and that is what you aim for in the survey. If you see it's 4 to 6 diopters till 6 months and less than 4 at 1 year, and thereafter mild hyperopia. Of course, we used to use SRK, but now it's SRK2. The Barrett Universals 2 is still needs more research in children. So coming to the surgical strategy, you have a lot of things going on. You have a low scleral rigidity here. You have a small eye. You have a poor pupillary dilatation. You have an much more anterior elastic capsule. High risk of inflammation, high incidence of PCO leading to amblyopia. So all these things, one has to very accurately plan your surgical steps. So I'll just be taking you through some of these things. The first one is you need a well-dilated pupil. In children, meiosis is a big issue. So you can see we had used drops in this child, but did not dilate. Now what you're putting, you just put the intracameral dilator and the pupil has dilated. And it would be there till the end of the surgery. So this is the most important step when you're starting a surgery, because everything is going to depend upon the pupillary dilatation. So these intracameral dilators are really helping us. Again, the second case, you put trip and blue dye, the pupil constricts. What you have to do is intracameral dilators. So that's how the pupil dilates. So this is something what we published, and you can see how well the pupil is dilated, and it maintains the stability till the end of the surgery. Next come your curvilinear capsular axis. You have to have a centripetal force in all these conditions. So you always stain your capsule because it makes it less elastic, and then gradually with the centripetal force have a 5.5 millimeters type of a anterior rhexis. So you can see here, this is some things we encounter here. You don't with a Utrata capsule. Now you use a vitrectorhexis because of the fibrosis you can see on the anterior capsule. So it's not coming up with the rhexis forceps, and what we're using is a vitrector. So always stain, and you can use different ways of doing your capsular axis. Lens matter aspiration, very important. Do not allow fluctuations in the anterior chamber. The more the anterior chamber fluctuates, the more inflammation. So you can see I'm not changing my ports. It's all done with the same port. The irrigation aspiration from one side, it's not coming out, you're not changing hands. So the lens matter is all being aspirated just with in one go. So that will not allow fluctuations of the anterior chamber. So it's a non-edited fast video, and we'll be just seeing that it'll be all finished within without changing your ports. So that's it. So why capsulotomy and when? Of course, all children less than 6 years, maybe 8 to 10 years, depending upon the cooperation of the child, depending upon the status of the posterior capsule. So there's a high rate of PCO, so you would have to do a posterior capsulotomy and anterior vitrectomy in these cases. There are different techniques. You could do a posterior rhexis, manual posterior rhexis, a vitrector-assisted capsulotomy, and some people do a radio frequency. So here what happens is when you're doing this capsulotomy, you always stain the vitreous with the triamcinolone because it's a limited anterior vitrectomy what you want to do. So it just give you an idea about the completeness of your vitrectomy. So you could do a posterior rhexis using a Utrata forceps here. So sorry, I'll just go there. Yeah. So we're using Utrata forceps, and that's how the posterior rhexis was done. Or you could do it after IOL implantation as well. Stop this. So you can see that the capsule is really friable here. So if I do it manually, during my first attempt, it might go larger and you might not be able to put an IOL. So it's safer to put the IOL and use a vitrector through the limbus. But you can also do it through the pars plana. If you find that the size of if the bag is tight, the IOL is little larger size, probably then going through the anterior route, you might tear the anterior capsule because you have to go behind. So you can see here, I'm going through the pars plana and doing the posterior rhexis. So these are different ways of having less inflammation and achieving good results. And the other thing is probably the last thing what I would like to mention here is not in the bag, but you can put your IOL behind. That's the posterior optic capture. So what we are doing is you have this IOL in the bag. So I put the IOL in the bag. The optic is going to go behind the posterior capsule, and the haptic is going to be in the bag. So what this does is it makes the anterior and posterior capsule fuse together. So when they are fused, you can see in the picture on the right, what happens, the visual axis is clear, a sombering ring is formation, and all the epithelial cells are sequestered in the bag because the bag is sealed.
Just please, can you summarize?
Yes, sir. Yeah. So take home points, biometry, A-scan with handheld keratometer IOL master, use SRK2 or Barrett, refractive goals, 4 to 5 diopters, less in unilateral cataracts, the optimal time is 6 to 8 weeks, use intracameral dilators for addition, and all children less than 6 years should have an anterior vitrectomy with a PPC, and primary IOL implantation in those above 6 months, and occlusion is the key for better outcomes in unilateral cataracts. Thank you for your attention. I just want to finish up with this video. A good aphakia is much better than a bad pseudophakia. So this is an aphakic, less than 6-month-old child. He's looking for his glasses. And you can see here how happy he is wearing his glasses. So this is a good aphakia which has been done, and probably over the years, he might have good vision. I cannot predict how much he will have. Thank you so much.
Thank you. Now I'll invite Dr. Anand Parthasarthi. He's going to tell us about achieving good keratometry readings in post-keratorefractive surgery eyes. Dr. Nivian sir, your presentation is loaded.
Good morning, Dr. Bhalla and the chairperson. Thank you for inviting me to be a part of this lovely symposium. I keep the topic just to getting accurate K, and I'll start with one of my presentations. Of course, the simple answer is get a biometry, but the depth is probably in how you do it. No financial interest, but it would be nice to have some. So I guess getting accurate K is like nirvana for most surgeons because that's an important part of achieving what you want to really get. And I'll start with this patient of mine who's in the business of government contracts, diagnosed to have cataract in another hospital, history of RK done 10 years back with a myopia for about -8. Now her children are doctors, a son is a clinical trial specialist, has done intensive research on different types of IOLs and me, has read all my papers published, has a discussion with me on my PCR rates and number of premium IOL surgeries done, and son discusses the average post-operative results including the confidence intervals. Now doctor also wants to come in and observe surgery, and patient's preoperative preparation included antibiotics, NSAIDs and dilating drops, and my preoperative included prayers to all the gods, including the 33 million gods that we have. Luckily for them and me, the surgery actually went off perfectly. Now this is the pre-op pictures, and you can make out that the RK incisions are about 70 to 80% depth, and this is an important factor when you actually decide to plan, because if you have full depth or you have epithelial inclusions, you would probably need to be careful of where you place the incisions. But majority of the time, it's a good idea to do limbal or scleral incisions in post-RK patients. What was important was, if you can look at the keratometry, it's a fairly regular axis. So we did plan for a toric multifocal in this patient. And post-op, the results were quite good. In both the eyes, the patient got good vision with 6/9. At the end of the day, the hospital were happy with the income. The patient's family and I was happy with the outcome. Now, this research was done in the morning. So there is still some research being done on post-keratorefractive patients, because this is not in the normal range. Because for us, majority of time we can hit 0.5 in a normal patient, but these patients require a bit more of focus, because these are post-refractive surgery, ectasia, spore keratoplasty, and post-RK would be about 80 to 90% of slightly more difficult patients, and how well we do in these situations is important. In normal eyes, we know there is good evidence available both from the NHS and published data. The 0.5 is quite easy. But what about these patients where the accuracy tends to drop? Now, there are some sources of error. One is the axial length, second is keratometry, third is the effective lens position. And if you have a previous RK, that is, we do know the theory behind it, that there's a change between the anterior and posterior curvatures, and we need to also look for smaller optical zones, because if you have a smaller optical zones and you're putting an IOL with a central addition, they will struggle, because there is multiple refractive divisions across the whole pupillary area. There is, of course, a keratometric index error, because there is a change in the anterior to posterior curvature, and that's why the refractive index tends to change. The effective lens position, most of the formulas base it on the axial length itself. So if you have correct axial length and keratometry, the effective lens position most time is an estimation. That's why it's called estimated lens position. And usually 0.25 to 0.5 variation in the position can change your refractive error by about 0.5. Manual keratometry, probably just for the record, but most of us would have shifted to automated keratometers along with very good imaging systems. I have done this in my postgraduate and fellowship, but it's not an easy thing getting good keratometry readings and manual if you have had some surgery done. So may not be my most primary approach, but for postgraduate training, it's not a bad idea just to understand the principles. Most of us have shifted to automatic keratometers or with biometers linked with 18 or 32 points, and this gives a very, very accurate amount, because the chance of it changing from this is very accurate. You do measure the central 3 millimeters quite well. The Placido-based Scheimpflug, now you have OCT-based TrueCase, and of course the hybrid, the iTrace. Out of this, my preference is for the Scheimpflug and Placido, because I feel the anterior cornea is an important part of making sure you get the right result. So if you got a good ocular surface, which I think has been mentioned, and then you do these Placido-based systems, it usually helps. Now, there is fair amount of data on EKR in pentacam, which is basically the effective corneal power in the central 4.5 millimeters. So you have that in normal, LASIK and RK. Now, the challenge in RK is you have a very, very wide spread. So 32 to 42 in some of these patients when you get. Now, this is a challenge, because you cannot use that. You use the average K and you got a 13 diopter difference across the central optical zone, you will struggle with post-op results. So the ideal optical zone in looking at pentacams or any of these Scheimpflug images is to probably go slightly higher. Usually 4.5 is what I prefer. Now, a topography or a Scheimpflug based image is probably a more reliable system, and you get a larger diameter. EKR in pentacam is there. There is something called TKR in IOL Master. The OpScan has something like TMP. This has already been covered, but I think as surgeons, not using this is probably not correct, because the IOL master printout or your biometric printout is basis. Always try and cross-check with online. The ASCRS is very good. My accuracy is about 1 diopter for these, and in post-RK, post-LASIK, I aim for about -1. I would not go through this, but broadly, most of the present online calculators have an accuracy of about 90%, which is actually quite good. This I would just also skip. If you have patients with keratoconus, remember the type of keratoconus is the basis of your results. If you have early keratoconus, it's usually not a problem. But in this, you have to look at visual axis, you look at the steep cane and position of the cane, because for a keratoconus patient, he may not be looking through the central part of the cornea, he may be looking at a multifocal, it's like a multifocal cornea, so he may not have that clarity of vision. So if it's a very eccentric cone, maybe a good idea to do a topography based treatment, centralize the cone and then try and do treatment, because there are multiple aberrations, predominantly vertical and trefoils, which actually affect the quality of vision. This is a broad table which I use. Anything up to 52, your regular case would work. Anything beyond 52, you will have poor repeatability. A good idea to actually go in, either put in a ring or do an ablation before you touch the cataract part. I guess there are two parts. Now
Anand,
everything is about AI.
Anand, you need
Last
to
slide.
say, yeah.
The artificial intelligence. I think we need to understand the artificial part is the photos on your left. The intelligent part still lies with us, the surgeon. So make sure you use them. In conclusion, be aware of abnormal corneas. Only about 70 to 80% are within one diopter. Counsel the patient, maybe for some optimal outcomes. Be aware of the sources of errors. Use topographers wisely, and use IOL calculators online. Remember, RK corneas, recheck them, and keratoconus and mild keratoconus, moderate corneas very good results. I'd like to acknowledge some of my colleagues who helped me out with some of the calculations, and thank you so much.
Thank you, Anand. Now we have the next talk by Dr. Nivian, and he's going to talk on which IOL to choose and which is the right IOL, whether it is monofocal, multifocal, trifocal, or EDOF. Dr. Nivian, all yours.
Thank you, sir. So, respected teachers, senior ophthalmologists, my dear friends. Not this, Nivian. Changed to Nivian today. NIV and yeah. Yeah. So I'm going to talk about choosing the right IOL. So it's between monofocal, multifocal, CDOF and trifocals. So I do not have any financial interest in the presentation. So basically we heard from the previous speakers how cataract surgery is evolving and changing. So these are some of the drivers of good outcomes after cataract surgery. The first and the foremost is the safety and the efficacy. And the second thing is the efficiency. Efficiency, not only the efficient surgeon, efficient machines, and all the IOLs also have to work. So all three have to go hand in hand. And no longer it is just doing the cataracts, because as Anand said, have to correct the refractive things, and also patient wants spectacle independence. So choosing the right IOL, actually it was only the surgeon's choice before. So we always used to go based on the material, which was good, hydrophobic, hydrophilic, and about the design and the different types of haptics and the cost. And then what type of procedure will suit the patient, whether he's going to do a phaco or 1.8 or 2.8. And then post-operatively, we want less inflammation, no rates of PCO and dysphotopsia, and spectacle independence. So we should always, there is a trade-off between what will ideal for the patient and what the lens can deliver. So, but nowadays we have these patients who are more demanding, and there's like a new classification that I have done, like it's more based on the social cost, like how motivated are the patients, do they understand what is a trifocal, how the EDOF is going to help them. And second thing is about the friends. If they already got something, they come and ask you that I want to see everything at all ranges. So the demands of the patients have come in front rather than us trying to choose. Then the other causes, like what type of work do they do, what type of lifestyle do they lead, and also different makers and costs. They want the imported ones or Indian manufactured ones, and also the economics. As long as India is concerned, I think economics is a very important factor. So basically they want to read, they want to be on the laptops and screen, they want to do their driving, play with their grandchildren, at the same time not have any of the glare and halos. So basically we have these four types of lenses: the monofocal, the EDOF, the multifocal and the trifocal. So I'll just try to keep it very simple. As long as we know monofocal, they just give one range of vision, that is you have clear distance vision. And then the EDOF lenses, basically they work on positive spherical aberration. So basically what is done is that one point of focus is elongated. So patient has very good distance vision and then have good amount of intermediate vision. But then they do not have near vision. Multifocal lenses have been there for so many years, so I don't have to go through it, the diffractive technology. So basically they have 2 points of focus, that is distance and near, and the trifocal 3 points of near. So the best way to understand this was to do a study. So we did a study in our own hospital and comparing between these 4 lenses. So because basically before telling the patient what and how it works, so we wanted to do a study. So basically we took a monofocal lens and then we had a diffractive multifocal lens. So the basic thing in diffractive multifocal lens, they have lots of rings and the step of the rings are very sharp. So that is why they have more loss of light, less contrast and more glare and halos. So what the trifocals did is they started spacing out these rings and then they had intermediate vision and they had something called apodization where they rounded the edges. So the loss of light and this thing was lesser. So patient had definitely better contrast and less glare and halos as compared to the multifocals. But one simple point is when you have rings in any IOL, there is going to be some amount of glare and halos. So never say the patient that you will not have. So always keep them warned before surgery. The third thing, actually initially we did the study with the in-focus lens, but then we shifted it to the Rayner lens, the EMV lens or the extended monovision lenses. So these are a type of EDOF lenses where it's based on the postical spherical aberration. So you don't see any rings, no bulges on the surface. So it is just like looks like a plain monofocal. So then we did the study for 1 year and we compared the results, taking into consideration all the inclusion and the exclusion criteria. So I'll just move on to the results. If you can see in the first graph, as far as distance vision is concerned, I think all the lenses have good distance vision. So then when you come to the third graph, for near vision, you can see that the orange line, that the multifocals and the trifocals have very good near vision, almost N6 for all patients. But then there's a slight drop when it comes to the extended depth of focus lenses, and we all know that monofocal lenses don't work for near vision. And then the fifth graph, when you see for the intermediate vision, so here what happens in trifocals and the extended depth of focal lenses, you get good amount of intermediate vision that is basically ranging from 40 centimeters up to 80 centimeters where all your tab work happens. And then, oh sorry, thanks. Anyway, you can use the cursor itself. Oh, sorry. Yeah. So as long as the intermediate vision is concerned, you can see that the trifocal group and the extended depth of focal group works. So this gave us a broad idea about how these lenses work, and it made it easy for us and our counselors to counsel the patients depending on what is needed for them. So this is again the defocus curve that we did for all the patients. So as you can see, the blue line, the monofocal, they are very good at distance, but then there is no intermediate or near vision. It's a very simple graph that can be done and to the patient for us to self-analyze and to see how the patient sees at all distances. The second orange line, as you can see for the multifocal lenses, as I said, 2 focal point. So up to 2.5, they have good reading vision, but in between, they don't have the intermediate vision. The trifocal lenses, as you can see, there is one at 1.5 and another peak at 3. So because they have the 2 zones, so that is why they are good at this near vision and some amount of intermediate vision. But it happens only at 2 peaks. So why that 2 peaks is, again, there is some amount of loss when it comes to one area where there is no elongated focus. They just have 2 focuses. But then last, when you see any of these extended depth of focal lenses, they have good vision, they have good amount of intermediate vision and considerable amount of near vision up to 2 to 2.5. So that is why when we do EDOF, sometimes you have to tell them, if the patient wants only reading vision, go for a multifocal or trifocal. If they need to do more range of vision, like playing something or just tab work, we always suggest them for EDOF lenses. And if they're going to be driving and very young age and active. And nowadays, what I would say is like monofocal lenses are slowly phasing out, and then I think that's where the EDOF lens space has come into. Like instead of a monofocal, you're giving an added advantage to the patient. And the second thing with the EDOF lenses is for glaucoma patients, for retina patients, where all these were contraindicated for multifocals and trifocals. Now you have another lens that works for that also. So as long as the contrast sensitivity, yes, monofocals are the best. But then the second best was the extended depth of focus lenses. Any of these lenses that do not have a ring have
Niveen,
good contrast.
Niveen,
Yes, sir, done.
please sum up.
Last slide. Yeah. So basically, yes, considering the surgeon's experience with IOL technology would be better than just going with the marketing strategies. There is no single multifocal or a EDOF lens that will suit all patients. So we should know the needs of the patients and then have a holistic approach, be patient-centric, and considering their visual goals in life. Thank you. Thank you, sir.
Thanks, Niveen. Yeah. Now the next speaker is Dr. Sachin Mahuli. Sachin, we are running late, so please
I'll try to
make it
finish.
short. Yeah. And Dr. Banashri, you be ready with your, yeah. Sorry
So-
for the delay for the next session, but we will finish in 5-10 minutes.
Good morning, everyone. I'd like to thank Dr. Balla and the AOS Scientific Committee to giving me an opportunity. I'll be speaking cataract surgery, especially in cases with post-retinal surgery. So there are problems which you can encounter pre-operatively, intraoperatively, and post-operatively. We'll just quickly go through the problems. A pre-operative assessment is very important in post-retinal surgery when you're planning a cataract surgery. Vision, fundus assessment, biometry. If there's a silicone oil in the anterior chamber, visualization of the fundus will be difficult. Corneal issues like scar in cases of trauma. Biometry in silicone oil filled eye is very challenging. Optical biometry is very accurate in most of the cases, especially you should remember when post-buccal the eye is elongated, we may have a myopic shift. It may be up to 2 to 3 diopters. If there's a corneal scar related problem, then you will have a astigmatism which you really cannot measure. Quickly, silicone oil filled eye, you should always check pre-operative refraction. You should have the records of pre-operative refraction so that you'll get a fair idea of the biometry. Compare the biometry with the other eye. It's very important to assess the IOL power. Refractive surprises are very common, and especially in very high myopes, these things can be challenging. Special problems during planning the surgery is like the cataracts are really hard, leathery. A pupil may not dilate to your expectation. Anterior chamber may be shallow or very deep. Either ways, PC plaques will be there, especially if there's a lens touch. Or it could be a silicone oil used lens touch also. If the pupils are small, use hooks, rings. Don't hesitate to use these gadgets. Rhexis may run away if the cataract is very intumescent. I'll quickly show a video later on. If it is a very leathery cataract, then you'll have difficulty in chopping and emulsifying the nucleus. Zonular weakness is very, very common, especially in cases of post-buccal or a long-standing silicone oil. So if there is a lens touch, it's always documented. PC dehiscence is very common in cases when there is a complete lens touch. So difficulties of hypotony, deep AC and emulsified oil in the AC should be thought of, especially when there is a case like this. You would first do the AC wash and then assess, because everything will be white. You won't be able to see grade the cataract. So once you clear the silicone oil in the anterior chamber, you'll be able to see what type of cataract are you dealing with. Section and tunnel related issues, you should do a very good tunnel, especially the watertight tunnel achieving is very difficult, especially in cases of hypotony. So use liberated viscoelastics. Rhexis related issues would be a poor red glow, intumescent cataract. Argentine flags are very common in fibrotic entry capsules, especially in oil filled eyes. Use scissors, forceps and stain the capsule. This is a very quick, I'll just show this video. This is a case of intumescent cataract in a young patient. After staining the capsule, you can see the rhexis started running away. Very typical of intumescent cataract. So in this case, the lens was very soft, so we could just aspirate the lens with the phacoprobe. You can see a PC plaque there. IOL was implanted. Then the rhexis was completed using the scissors and forceps. After placing the IOL in the bag. So once you finish, these PC plaques need to be managed. Either you can do it post-operatively through YAG capsulotomy. This is a case which I was doing a SOR after the cataract. So I managed this PC plaque using the cutter, because these plaques are sometimes very difficult to YAG it post-operatively. So you can use a cutter to do a nice PC opening and then complete your vitreoretinal surgery, either SOR or whatever additional surgeries you are planning. So handling the nucleus, you preferably would like to do a direct chop in most of these cases.
Sachin, can you just come, please?
So we have already discussed these larger optic IOLs need to be considered when you are doing this. Post-operatively, always look for inflammation, cystoid macular edema and other complications which you are which you can anticipate. Be hopeful. Meticulous pre-operative planning and very steady intraoperative procedures can get you a very good results. Thank you.
Yeah, thank you, Sachin. And the last speaker is Dr. Vanashri, and I am sure she is going to.
Good morning, everyone. First of all, I'd like to thank Dr. Bhalla, sir, for including me in this session. I'll quickly go through this because of lack of time. So I'm talking about post-cataract surgery refractive surprise. In today's world, the definition of a refractive surprise would be any deviation from the intended target that we have kept for the patient, so which can be highly unsatisfactory for both the patient and the surgeon. So there are a lot of factors like preoperative, intraoperative, and postoperative which can lead to a refractive surprise. I'll not go through the details because this has been covered by the previous speakers about doing a correct biometry to measure the correct effective lens position using of the appropriate IOL formula and then reaching the exact IOL power that we need for that patient. But there are certain conditions, as we know, that people like those having a high hypermetropia, high myopes, post-refractive surgery patients, dry eyes, post-keratoplasty patients, these are the ones where you'll have faulty biometry and we need to be extremely careful with the use of your formulas. So I'm not going into these details. Coming to directly, if now we have a situation where there is a refractive surprise, so what do we do? So we need to find out what was the exact cause, what has gone wrong, so that we can correct it. So do a subjective refraction at post-operative 1 month if it is your patient. Do a complete dilated examination. Recheck the patient history, surgical records, the IOL formula used, the choice of IOL that has been used. Repeat your biometry, keratometry. Do an OCT of the macula to see if there's any cystoid macular edema. And if none of these factors have gone wrong, then probably there was some error in the calculation of the effective lens position. So the first thing to do is medical management actually. You have to determine the patient's expectations. So we need to give an adequate chair time to discuss the situation, be honest with the patient that, okay, this has happened, this is your refractive error at present. So what is his expectation? If he's okay with a little bit of myopia of -1, you can say that, okay, you'll have a little bit of better reading. Or if the patient is totally unhappy, then we have to, go ahead and do something more and get the patient to probably emmetropia. So what are the options that we have? So first is your IOL exchange, or if it is a toric IOL, then it may be needed to be rotated. If the IOL has got fixed into the back, then it is piggyback IOL is the option. A very good option is cornea laser refractor based procedures, that is PRK or LASIK. And another recent advance has been the light adjusted IOLs, but we don't have it in our country as yet. So another thing to remember is you could have a capsular block distension syndrome. So there could be viscoelastic which could be stuck behind your IOL in an early case. So that can cause a distension and pushing of the IOL anteriorly, and that could be giving you a myopic surprise, myopic shift. So please do a careful slit lamp examination, because here you don't need to exchange the IOL, but just do a capsulotomy to release the visco or the fluid. So if it is a monofocal IOL and the patient has come early on, with like 2 to 4 weeks after the surgery, so what are your options? So the first option here would be an IOL exchange, because if it's a hydrophilic lens, then you can easily go and change the lens. Even in a hydrophobic lens, in early situations, you can easily go ahead with an IOL exchange. Second option would be a piggyback lens, and third would be PRK. But if the patient is coming late, say after 4 to 6 weeks, then adhesions would have formed, and piggyback lens would be your first choice, and PRK, and again LASIK, but you'll have to wait for 3 months if you want to plan LASIK. I'll just talk about the toric IOL surprise. Now, if you have a toric IOL surprise, then the tool to use is astigmatismfix.com. This will actually give you the idea whether the IOL that you have placed, is it going to help only by rotating the IOL? Can you reach to a good refractive error at the end? So what you have to do over here is you have to feed in, if you can see the cursor, you have to feed in the cylinder power of the IOL that you have used, the axis at which it has been placed, and what is the current refraction of the patient. If you feed this data, then the software gives you an idea whether rotation of the lens will help or not. Now, if you see this example, here rotating the IOL will not fully correct the expected refraction. Hence, the way to go over here won't be a rotation, but you'll need to exchange the lens. Quickly talking about the piggyback IOLs. Basically in piggyback IOLs, you need the primary IOL to be intact in the capsular bag. You need a deep or a normal AC. There should not be glaucoma or pigment dispersion. and the endothelial count should be normal, and it is the choice of procedure for hyperopic errors. So these are the calculation formulas that you can use for the same. So this is the Sulcoflex lens that is one of the examples, a very good examples of piggyback IOLs which we can use. And I won't go into the details of the light adjustable lenses now. LASIK we can plan, but that's a very good option for small errors, but we need to wait for 3 months after the cataract surgery. PRK can be done after the refraction has stabilized. The important things to remember is thin corneas, Fuchs dystrophy, basement membrane dystrophy, or severe dry eyes. These are contraindications, so we need to be careful here. A word of caution, any additional surgery will be carrying a risk of loss of best corrected visual acuity, infection, complication related to the anesthesia. Now these risks are always slightly greater than the initial cataract surgery. So we need to be careful, weigh the pros and cons, and then go ahead with what we plan for the patient. Thank you.
Yeah. Thank you, Dr. Banashri. Yeah. With this, we come to the end of our session. Thank you. And sorry for delaying you.